Yeah, yeah, that's where I usually go.
Yeah.
All right, I want to talk about the accelerator and the brakes modifying the algorithmic cells. Accelerate the heart rate, increase heart rate. We have the cardio-acceleratory center. The brakes, which would decrease heart rate, that is the cardio-inhibitory center. Brakes. Yeah, I really can't spell this early in the morning. Brakes. And, well, we call it a decrease in heart rate a bradycardia. And we call an acceleration in the heart rate a tachycardia. Those terms are also used. And the nerves are shown here. The cardio-acceleratory, there are sympathetic efferents at the level of T1 to T5 spinal nerves. Okay. They're colored green there. T1 to T5. Those are the sympathetic efferents. So those refer to the spinal nerves, not the vertebra. Okay. The brakes, there's a branch of the vagus nerve, cranial nerve 10, that purple nerve that they illustrate there. That's the nerve that carries the parasympathetic efferents. The vagus nerve. All right, so, well, here's a picture of how the autorhythmic cells would be affected. At the top frame, you have kind of a normal standard firing rate, which would establish a heart rate of 75 BPM, or textbook average. The effect of acetylcholine from the vagus nerve, a couple of things. You're starting from a more negative potential, and it requires more time to reach threshold. So that's two things to note. Okay. All right, so one thing to note for the brakes, it's over here. You're going to open more potassium channels. Open more potassium channels. And what that allows you to do is you start from a more negative potential. You've increased the hyperpolarization. Increase polarization. So you're starting more negative. So it's going to take you longer to reach threshold already. Okay. So if that's kind of the normal hyperpolarization, the vagus nerve will allow you to kind of like start even more negative. Okay, so start more negative. The other thing that's happening is it takes longer to reach threshold. You're kind of decreasing the slope of the pacemaker potential because there's less cyclic AMP. So you close more calcium channels. So that is the second point to note. Cyclic AMP is a second messenger. The net effect is you close more calcium channels. Now, I know calcium channels carry the depolarization. I didn't teach them as affecting the pacemaker potential, but they do. When you close more of them, it takes longer to reach threshold. You decrease the slope of the pacemaker potential. Decrease slope, the steepness of this pacemaker potential. So that's where I'm writing. Decrease slope of pacemaker potential. So if a normal slope is something like that, it's like you kind of decrease the slope a little bit. You just kind of make it more flat. Kind of exaggerating, but instead of being more steep or less steep, it just takes longer. That's what you see illustrated here. So the bradycardia is down to like 40. Did any young person have a resting heart rate of like 40? Anywhere in the 40s, your heart's doing good. It's not working hard. Anyways, that's it's taking you longer to reach threshold. Now, so let's compare this picture to this picture here. This is the accelerator. You may have observed this post-exercise. If your resting heart rate's above 100, you might want to go talk to a doctor about that. But anyways, the accelerator has an effect of, well, it's kind of the same couple of things in reverse. You're starting from a less negative potential, and you're increasing the slope. And so what happens is, when the accelerator is on, the effect is you open the funny channels earlier, and you open more calcium channels. Number one, open funny channels earlier. So you start less negative. And secondly, open more calcium channels. The opening of the more calcium channels allows you to increase the slope of the pacemaker potential. Increase the steepness, increase the slope of pacemaker potential. So this is normal. Accelerated might be something like that. If you want to draw it, if it helps you kind of make more sense of it. If you just look at the picture, it's not enough, but draw it out, make it real to you. The figure says it all. You've reduced the repolarization, the more rapid depolarization. So they call that the accelerator at the cell level there. The net effect, you're reaching threshold in less time for a faster heart rate. So again, another easy question, I think. I got to show you normal. If I show you a normal, what effect is that? Sympathetic or parasympathetic? Parasympathetic. It's really easy if you understand the concept, as long as you have a baseline to look at. 75 BPM, 40, 120. To finish up, I want to talk about cardiac output. There's some calculations we like students to make, and there are some concepts about stroke volume we like to address to finish up the heart chapter. So let's talk about how you modify heart rate and stroke volume. We just talked about the modification of the heart rate, that. But let me show you the next slide. This is kind of an outline of what I'll talk about next. What I want to talk about now is that cardiac output is a product of heart rate and stroke volume. So that means you have to multiply here. Let's do that. Well, heart rate is the number of beats per minute. Stroke volume is the amount pumped out by a ventricle with each beat. In the condition of rest, it might be 5 liters a minute. Could increase quite a bit with exercise. Cardiac output, CO, product of heart rate times stroke volume. So, for example, given that information, could you do the math? Let's do this together on your half sheet. I want to see that you can do it. We're on number 4. Calculate cardiac output given that. We're going to do it together here. Cardiac output equals 75 beats per minute. We multiply that by 70 ml per beat. What units cancel out? Boom, boom. What units are left? Mils per minute. That's 75 times 70. More than 4,900. Oh, calculator. Might be good to have one of these for the test. Calculator. Oh, 5250. Okay. What if I put as a multiple choice? I didn't put 5250. I put. What if I did that? What did I do to go from mils to liters? What's the thingy? There's 1,000 milliliters in 1 liter. Now I remember, last summer, I had one student. She was like, "Oh, what? No, you didn't put mils." And she got really flustered when I didn't put that because that wasn't the problem. I can do that. Okay, you're expected to know that. You took chemistry. I didn't ask, what'd you get in chemistry? I got an A. Oh, seriously? It didn't do you much good. I mean, dude, this is like pretty basic stuff. The whole units cancel. Do you remember doing that in chemistry? That is the most important skill you're going to get from chemistry. I used it all the way through grad school, nonstop. The whole units conversion thing. So get good at that if you're going to take anything away from chemistry. In addition to all other great things you learn there. The math is an important component in science. and in the healthcare profession. So I think that's an easy calculation. Now conceptually, we talked about all these things. You should know what it is. And stroke volume, that's the amount you eject. Of course, this is important. This is how much of inflow you had. It's how much was available to pump. Now for those of you in the front, can you see how much the EDV is? That says 130. Okay. And how much did you eject? You ejected down from 130 to 50. So how much did you eject? Well, what you could do is call it half sheet number 5 and just tell me. If you have to use a calculator for that, please don't. Just try to do it in your head. Just be quick about it. Number 4 was cardiac output. Number 5, you're putting stroke volume. I want to see if you can do the simple math. I think you can. Sometimes students like to check them use a calculator anyways. I think you're wasting time. Just try to get through as much of the test as you can. And if you have time at the end, you can check your math on some of these. Now this, you will need a calculator. Ejection fraction. We'll call this number 6. Well, no, we won't do it because I did it for you. But you should know how to calculate ejection fraction. The ejection fraction is the percentage of the EDV that you pumped out. So it's a percentage. Ejection fraction. So we got it to number 5 on the half sheet. But you'll also be asked to calculate ejection fraction a percentage. Percent is always, and again, I remember this from chemistry, part divided by the whole times what? 100. Boom. Now let's put it in context of cardiac cycle. What is the amount of blood available to eject from the heart when you finish inflow? The E, D, V, right? So that's our whole. So I'll put that in the denominator. The part is how much we pumped. With each heartbeat, the volume you pump out. What do we call that? Stroke volume. Okay, so that's the percentage you're calculating times 100. So whatever that fraction is, in this case, these numbers, 61.5%. That's how you would set it up. You will be asked to do that at least once on the exam, okay? Just given these values. All I got to do is show you something like this, and you should be able to figure it out. You got that, boom, you're good, okay? Or let's do it this way. Okay, what are we on the half sheet? Are we on 5 or 6?
6.
Okay, 6. I want to see stroke volume and ejection fraction. Go. SV. For SV, we'll go units of mils. For ejection fraction, it's percent. I'm done. You guys get it? Everything you need is there. I'm reading the room. I think you're a little lost. What's EDV? 120. Where did I get that from? You start filling at A, finish filling, EDV 120. Push it all out, boom. What's my stroke volume? The difference between 50 and 120? 70. Okay, so I'll spoon feed you a little bit. I know you're still in preparation mode. Boom, boom. And practice later and get good at it. Okay, I want to move on from the math. Math is your friend. Don't be afraid of it. It's easy once you figure out the concepts. More concepts, though. That's a 58.3. Sorry. So the reason why I thought that was a fair question, I mean, didn't I teach this figure? It does look familiar, right? I mean, I'm not trying to be sarcastic. But immediately I want you to see, you can calculate things from it. You should be able to do it quite easily. So you can rehearse that more if you need to. I know in the context of a lecture, you may not click real quick. Here's a concept map of what I want to go over now. I want to talk about how cardiac output can be affected by both of these things. This I already talked about. You want to increase the cardiac output, wouldn't you use the accelerator and not the brakes? And that's the basic idea. Okay. So that already addressed. Didn't talk about this so much. You can modify the stroke volume by affecting preload, afterload, contractility. So those are the three ideas I want to talk about conceptually. And so here's an outline of preload, afterload, contractility just to give us an overview. Now, a lot of physiology are just terms, and sometimes the terms change, but the concepts don't. And preload is one of those terms that we already talked about, just said in a different way. Preload is the EDV. It is the end diastolic volume. It's the amount the ventricles are stretched by the blood filling the ventricles. That would be the EDV, the amount of inflow. Okay? So just stated a different way. So, but now, instead of just thinking as a volume number, 120 mils, think of that volume of blood stretching the ventricular walls. So the idea is, the more you fill, the more you stretch, the harder you pump, you increase stroke volume. More you fill, more you stretch, increase stroke volume. Preload is increase preload, increase stroke volume. That's the basic idea. That's the relationship. Next point, afterload. Afterload stress. It's related to ESV. That's the amount left in the heart. What it literally is a back pressure of blood from the large arteries leaving the heart. So let's remember that there's a blood vessel, and you have a semilunar valve that's closed. And when it's closed, there's a big column of blood sitting on top of it. So let me color this in with red because it's filled with blood. So this big column of blood is pushing down on top of the semilunar valve. And if you want to pump blood out, you have to create a big enough force to counteract that, as I call, back pressure, right? A back pressure is what I'm writing in. So the relationship is, if you increase afterload stress, what do you think is going to happen to the ESV? Increase. So by default, if more is left over, you pumped less out, you decreased stroke volume. So that's the general relationship you should get out of that. The third thing is contractility, and I already talked about that. Contractility. Fancy way we say is ventricular performance. Basically, how hard is your heart pumping? Okay. I said that all muscle fibers in the heart are already contracting. If you want to increase contractility, you have to make each muscle cell contract harder. Well, I think it's easy to understand. If you increase contractility, increase stroke volume. The heart's beating harder, you'll eject more. And you see that with exercise. Not only is heart rate elevated, contractility is too, although you can't directly measure that. So I want to kind of unpack each of those concepts a little bit more. Preload, afterload, contractility. And I want to introduce a law of the heart called the FRANK-STARLING law of the heart. It's associated with preload. So, preload is ventricular filling, the extent of ventricular filling. They show preload and afterload on this heart. Over the years, I noticed a mistake on the afterload picture. And the preload picture is right. Excuse me. When you have inflow, the SL valves are closed and the AV valves are open. And you're filling the heart, and I like how they illustrate the stretching of the ventricular wall during inflow. Now when you start to contract, you have to push the blood out the semilunar valves, but these valves are closed, but they didn't illustrate them closed. That's a mistake. But it's okay. The concept is still correct, that preload is the filling time, how much you fill. And the reason why I put that is the FRANK-STARLING law, very simply put, is more in, more out. FRANK-STARLING, capital S. FRANK-STARLING, law of the heart, more in means more out. Essentially, that's it. Increase preload, increase stroke volume. The more you fill the ventricles, the harder they contract to eject the increased preload. This ensures that the heart will pump all the blood returned to it from the veins. That's the FRANK-STARLING law of the heart. It basically says you increase preload, increase stroke volume, and we've already noted that, okay? And so, you know, this is important because I said earlier, to go back just to that previous picture, they're filling at the same time, and they're rejecting blood at the same time, the right heart, the RV and the LV. And so they have to have equal output. If one of them increases their output, say the right heart increases its output for whatever reason, right heart increases its output, goes to the lungs, comes back to the left side of the heart, you're increasing the return there. So then by FRANK-STARLING forces, this is going to increase because you're stretching it more. So that way they can keep up with each other. You ensure that the cardiac output is equal. Okay, so let's get into the why here. Why do the ventricles contract harder if you fill them more? And the answer is that stretch that we noted earlier. By increasing the filling, you're increasing the preload, but what you're really doing is stretching that bag, the ventricle, a little bit more. And what you're really doing at the microscopic level, you're reaching that optimal length tension relationship of the sarcomere. And that is where you're getting your increased force to contract harder and increase the stroke volume. So that's the good thing to know. The reason why you have more out when you have more in, because more in, increased stretch, and because of that, you reach a more optimal length tension relationship at the sarcomere level. I'll just say reach a more optimal length of a sarcomere. Now, if you forgot sarcomere, that is the smallest functional unit of muscle, or I should say the smallest structural unit of muscle. So you're going all the way down to the cell level with the sarcomere. Okay, so you remember how you had the thick filament, like I drew earlier, and then you have the thin filaments that overlap. Okay, so there's this graph that we have. That's actually for skeletal muscle, this one, but the cardiac muscle will be similar. And what you see is that, for example, when the muscles are overlapped too much, there's no room to slide because these slide towards each other. But if the muscle's already slack, there's no room to slide and you can't generate very much tension. But as you fill the cardiac muscle and you stretch it out, you start to stretch it out to the point where this optimal length here, now there's still plenty of overlap and there's room to slide towards the middle, the M line. Okay. Now, if you overfill the bag, you have no overlap and you can't generate any cross bridges, so you can't generate tension either. So there's that optimal area here. And the thing about the heart is it has the pericardium, so you can never overfill. Okay? You just basically, if you fill, you reach more of this level here and you generate more tension and you increase the contractility. Okay? So that's the why behind the more in, more out, because of the Starling forces due to this relationship. So with increased preload, ventricles are stretched because they're receiving more blood, so they contract more forcefully. This ensures equal cardiac output by, both ventricles, RV, LV. Any some increase in the RV is automatically matched by LV because of these Starling forces, as they're called. So the bottom line, increased preload, increased stroke volume. That's good for you to know. So any questions before I move on to afterload? That's preload. Starling forces. Afterload is, here's a good picture of it. I remember my professor always likened it to a bench press. Okay? But what I drew earlier is this, a big column of fluid sitting on top of the valve. That's what you have to press, right? To pump blood out of the heart. So that's what we're talking about here. That is the afterload stress. I think I asked this earlier. Here's RV and LV, just to review something I said earlier. Remember how I tricked you? I said the LV generates more pressure than this, so then I asked you, oh, which ventricle ejects more? And most people said LV, and that's wrong, right? Look at this, the output is the same, yeah. What I'm pointing out here is I point to here, that's about 10, and I point to here, it's about 80 or 90, 80, 10. So that's kind of like the afterload stress that each ventricle has to contend with. Okay, you have to overcome that pressure to kind of eject blood into the artery that's connected to it. Now, an increase in afterload stress has a negative influence on cardiac performance because you're increasing the workload for the heart. It has to work harder. Here's the relationship, which we've already noted. Okay, but here could be some clinical reasons why. Causes of increased afterload stress. Could be high blood pressure. Normal blood pressure is like 120 over 80. If it starts to get above 140 over 90, then that's considered hypertense. For different reasons. Maybe as we get older, our arteries get a little more stiffer. It's harder to pump blood into a stiff tube versus a stretchy, compliant tube. There's different reasons. But anyways, if you have to overcome a higher pressure every time you beat, that's a lot more work for the heart. And that can make the heart weaker over time. Atherosclerosis. That's the disease process, atherosclerosis. It means it's a hardening of the arteries. Anything that's sclerotic, hardening of the arteries. Hardening specifically of coronary arteries. With poor lifestyle over time, high cholesterol deposits, LDL cholesterol deposits can deposit in the arteries that supply blood to the heart. And over time they can calcify, they can become hard. And it makes the heart very weak. It can make the heart ischemic. And this is the underlying cause of heart attacks because of the plaques and the lesions. That's what they call them, lesions, plaques. This is inside those arteries, those very small arteries. You can see them on your sheet part. I didn't have you identify any of them. But I did have you identify the opening of the coronary artery. Do you remember how small that was? So imagine that small artery being filled with lesions or plaques. It becomes hard, and it makes the heart very weak. It's a lack of blood flow. Okay, so that could be a stress to the heart. And let's remember how the heart gets blood through the coronary arteries. Is it during systole or diastole? Okay, and the diastoles have it. So, because when it's in systole, the valve opens and it blocks the orifice to that. So the blood flow is restored to the coronary arteries only during diastole. But if you have a blockage there, that's not good. And if it ruptures and you have a scab on the inside of the heart, of a thrombosis, that might cause an infarct. if you have one, say, in the left anterior descending, the widowmaker, a big chunk of your heart muscle may infarct, and you may not survive that. A much smaller one, you might be able to survive. I mean, you'll know it. A person would know it. Myocardial infarction is scary. They call this whole thing, atherosclerosis leading to myocardial infarct, the silent killer. There's no symptoms. The myocardial infarction is the symptom. But by the time you've had it, you might already be dead, right? It's a little late. So that's why they call it the silent killer. One way you might know you have something wrong with your heart is you have constant chest pains, although that could be caused by multiple number of reasons. But in terms of afterload stress, if the heart is weak, no matter what the afterload stress is, it's a greater job for the heart. Okay. So those are all causes of increased afterload stress. Maybe the arteries are hardening, or maybe the arteries that supply blood to the heart are being clogged, or maybe you've had a heart attack, you're a cardiac patient. The contractility of the heart is simply how hard the ventricles are contracting. And I said this earlier, the skeletal muscle, if you want to increase force, you just recruit more motor units. But because the heart is a functional syncytium, all the muscle fibers are already contracting. So cardiac muscle depends on increased force by individual fibers getting a stronger contraction. And I've listed some ways on this slide how you can kind of get a stronger contraction out of each fiber. Contractility. Here are ways to increase it. To increase performance. Number one, I say, well, preload. I already talked about this, different way of saying the same thing. Do you want to up it or down it to increase contractility? Increase. Up it. More in, more out. That's the performance we're looking for, right? That's one way to increase contractility, and the why behind that is the stretch, better, optimal sarcomere length, right? And moving on. Number two, increase calcium's rate of release or its uptake. So I put a little picture of a sarcoplasmic reticulum. I called it the calcium sparks earlier this morning. So basically for number two, what you're doing is increase intracellular calcium. That'll help get the contractility going. Number three, increase the activity of an enzyme, ATPase. I mean, that'll speed up the cross-bridge cycle. Okay, if you get that enzyme that breaks down ATP more. Number four, sympathetic. Okay, so good old epi, norepi. Cardiac muscle has adrenergic receptors. So the old expression, a shot to the heart with adrenaline, that's what we're talking about here. The effect is that will increase calcium's availability and increase its contractility. Okay. All right. So if you want to increase your contractility by controlling your lifestyle, the best way to do it is to adopt endurance training. So I want to talk about how endurance training can increase cardiovascular performance just for a little bit. Endurance training increases cardiac performance. as we train, the heart becomes a more powerful pump. You increase the stroke volume. So the heart can do a much better job getting blood to the working muscles. And well, by training, you can increase cardiac output by about 20%. So if you kind of pick up a good routine for cardiac exercise, maybe about after a few weeks, few months, you'll definitely see this increase. So exercise that improves the cardiovascular system, it requires a few basic things. You got to use the big muscle groups. And exercise is technically, you're moving those muscles, you're using those muscles in a rhythmic fashion for a certain period of time. Okay, now that's the strict definition of exercise. Use the large muscle groups for a period of time. I'll just say large muscles. I mean, the best way to explain it is to give examples. Jogging, swimming, cycling. Now the best one is cross-country skiing, but most of us don't have access to that. If there's not some snowing outside, you can't do it. Unless you drive up to Tahoe on a regular basis. What about basketball? Would that be considered exercise? No, it isn't, actually, to be technical, because there's a lot of starting and stopping, but it's still healthy. It's under the bigger umbrella of physical activity. Exercise is a small part of that umbrella, like the elliptical, rhythmic fashion, okay? About gardening, physical activity, but not exercise. So you see the difference? But those things are great, okay? But I'm just talking about straight up exercise. Okay? The cross-country skiing, that thing, because cross-country is the best. You're using more muscle groups. Not only are you using lower body and core, you're using upper body as well. That's why it's considered the best. So the bout of exercise has to last a while. Okay, I would say 30 minutes, but they say at least 20 to 30 per bout. So every time you strap on the shoes, you got to keep it up for a certain amount of time. 3 to 5 days per week, and it's got to be at a certain intensity. So a better way to put that is what I call the fit factors. F-I-T-T-E. F is frequency. How many days a week are you getting out there? Yeah, 3 to 5 is good. For this audience, every day. Most days. Okay, 6, 7. All right, because most of you guys are younger and you have more capacity. As you get more busy in life, 3 is good. Okay. Now, so intensity. I is intensity. Now, we usually technically use VO2 max as a measure of intensity, but that's something very sophisticated that you can only do in a human performance lab. And now a lot of people are running around with Fitbits and stuff, and it's really easy to measure your heart rate. So the intensity ought to be, I already mentioned this, I think 70-85% heart rate max. You know you're in the zone, okay, to see the beneficial effects of exercise. TT is time and type. Time is the per bout thing, and they say 15 to 20 minutes. I said it'd be 30 minutes. I think that's pretty good. I mean, a lot of times if you're training for like a marathon, you're running for hours, okay? So it increases, but at least I think 30 is a good benchmark. Type. I think the best kind of exercise is, well, it's one that you'll do. It's the best type of exercise is one where you use the big muscle groups, right? I always, say this is an exercise. That muscle's not big enough to get your metabolism up. You got to use the big muscle groups for a long period of time to get your heart rate up. Okay. Okay, and enjoyment. You know, I think gym memberships pick up in January, and then they drop off really quick. Something to think about with October coming up. The traditional weight gain starts in October through the holidays, because what's in October? Halloween. You start eating that candy, eating my kids' candy, you want to watch it, and that's when the weight gain starts, and that's when you start your gym membership. But if you can enjoy it, you'll keep doing it. And it just won't be a New Year's resolution that fizzles out kind of a thing. So that's why we always include the E for exercise. So preload, the effects of endurance training. Your blood volume increases. Okay, that's remarkable. You exercise, you get more blood circulating. So you're going to increase the preload, increase the venous return, increase EDV, your increased stroke volume. That's great. Okay. Afterload decreases. Now, we tend to observe endurance athletes, they tend to have lower blood pressure. Now, we're not sure why. Okay, we're not sure why, but that's what we see. So that decreases the afterload stress. Contractility. With regular exercise, your heart becomes a stronger muscle. So you're going to contract more forcefully, and that's really going to help your heart rate. If with each heartbeat, your heart's contracting harder, the rate can drop. Does that make sense? Your heart loves that. I'll give you a couple of numbers, like normal resting heart rate, maybe at 70. Endurance athletes get down into the 40s. Okay. So just to give you an example, college student, Jane Doe, John Doe, let's say they train. And we know that the cardiac output is a product of stroke volume heart rate. (5,000 ml per minute). That's what your body needs. Say seated in a condition of rest, watching TV, or watching your iPad. I don't think people watch TV anymore. Cardiac, you're just sitting down rested. And what does your heart have to do to accomplish that circulation? If you just did the math, it's 70 ml per beat. Heart rate would be 71.4. Okay, but let's say you train, you get off the couch, and you're out there every day training, and you get the expected result that research shows, a jump in stroke volume. Now, cardiac output is simply meeting your metabolic demands, but it would change, for example, if you put on weight. If you gained a lot of weight for whatever reason, would that increase or decrease your demand when you gain weight? You increase it, but usually when you exercise, what happens to your weight? You lose it. But let's say it just stays the same, okay, for discussion purposes. You're exercising now. You bought your shoes, you got your app, and you're out there moving, doing whatever. And the stroke volume jumps from 70 to 84. To meet that metabolic demand, your heart rate drops to 59. Okay, so that's a simple example. There's other examples I could show you, but I think that drives home the point that training can reduce your heart rate. So here's a summary of everything we talked about. Here's all the things I talked about for preload. That's venous return. Okay, that's FRANK-STARLING. For contractility, that's a sympathetic nervous system, in case you're wondering what my abbreviations are. Okay, so that concludes the material for your test. And I do want to talk about that. I made some decisions about that. When's lecture exam 3? Monday. Okay, so you guys got that. Good for you. What I've decided to do I want to put lecture exam 3 on Proctorio. Okay? And when you use Proctorio, I always allow you to use whatever notes you want. It will be a timed test. I usually don't give lecture exam 3 on Proctorio, but I want to try it out this time. There's no written part. So this test will consist of 50 multiple choice questions, and I'll give you 90 minutes, which is the typical time I give for a test. Okay, so any questions on that? Everyone's getting a different test. I'm going to have a large bank of questions that I'm writing. I'm working on it now. I want to make it available Monday after class. I'm going to make it available all the way to Tuesday since we don't meet that day. So I'll give you an extra day to study and take it if you want to take it on Tuesday night. Okay, so that should make it a little easier for you. So maybe you don't have to cancel your weekend plans just yet.
Thank you. Thank you.
Yeah, no problem. The other thing I want to say is today, I've got another meeting. I won't be in my office again, but I will be here at 2:30. I have to stand in for Jeff for the first half hour of his open lab because he's at the coroner's office cutting open cadavers, and I wish I was there with him. I usually do, and I'm stuck here because I have responsibility to, you guys. So. But I will be here 2:30, for my semi-office hour. I have a meeting at 3, so it's like at 2:55. I'm out of here. You're not going to see me till Monday. So since we're having the test online, it'll become available after class. So I'm going to hit blood vessels next unit hard on Monday. Okay. So is there anything else I wanted to say? You also have a lab to turn in. And before you leave today, turn your half sheet. Boom, boom. Also, one other thing. I want to pass back part of your exam, lab practical, in the Scantron. Believe it or not, I haven't finished those essays yet. I am trying. I sat down all day yesterday reading those dang, I can't get through them. Every word has to pass my eyes, driving me crazy. But I promise I'll finish them by Monday. Okay. So I'm going to pass back your practical and your Scantron today, just so you get some feedback. Do you have any questions for me about the exam? Question? Oh, yeah. I was supposed to put another quiz, but as I was writing that quiz, I'm like, why don't I just put the whole exam on there, forget about that quiz? Right? Okay, so just worry about this. Forget about the quiz. Just do this. You can forget about that ugly quiz. That's how it all came to conclusion. All right, so you're dismissed. Don't forget to turn in your things. And in a few minutes, I will pass back the practical and the Scantron fourth paper test if you need to see that. Okay.